Okay, good afternoon, everyone. We're going to get started with our ground rounds. I'm happy to introduce. Hello, I'm Dr. Scott Ratson. I'm a distinguished lecturer in the Department of Community Health and Social Sciences here at CUNY School of Public Health. I co-direct the Health Communication for Social Change with Professor Chris Palmito. We're very excited today to have our guest lecturer for grand rounds here. We've had a whole series of these over the years, as many of you know, but more importantly than ever in our COVID age, if I can call it that, we've seen an amazing change in how we communicate about health and the misinformation and disinformation and world that we live in. And we're doing our best to try to help understand that and bring the best people in the world to help explain some of the challenges and opportunities, if I can say that. I'm very fortunate today to introduce Professor Dr. Carlos Del Rio to speak about crisis communication in the age of social media, lessons from SARS, Influenza, and Ebola. Professor Del Rio and I have been, well, fortunately, that I was able to participate in a meeting with him at the Global Vaccine Congress earlier in Italy, presenting some of our research that we've been doing at CUNY School of Public Health, but I know our dean, Dr. Ayman Al-Mohandes, and others who have just led this global consensus survey and Delphi analysis with Professor Romero and others on what we ought to do, frankly, from the end of COVID, but the next phase of COVID that's been published. Professor Del Rio also had participated in that and has an amazing career. But enough with just some of the background today. What I'd like to do is have an introduction. We'll go directly into the presentation, and then we'll have the opportunity for question and answer. And those of you who are not perhaps, I'm speaking to those of you who watched this secondarily, we have this live for question and answers, but we archive this for the whole series of grand rounds that we've been fortunate under Dean's leadership and others to develop. So first to introduce Dr. Del Rio, in addition to the great respect and that I've heard, not only at the presentation he made presaging this, again, recently in Italy, but also over the years with his work at the National Academies of Science, Engineering, and Medicine and other areas. I like to present Dr. Del Rio, who, as background, is the Leon Haley Distinguished Professor of Medicine in the Division of Infectious Disease at Emory University College of Medicine and Executive Associate Dean at Emory at Grady Hospital. He's also Professor of Global Health and Professor of Epidemiology at the Rawlings School of Public Health at Emory. He's co-director of the Emory Center for AIDS Research and PI of the Emory CDC HIV Clinical Trials Unit and the Emory Vaccine and Treatment Evaluation Unit. Dr. Del Rio is a native of Mexico, where he attended medical school at Universidad La Salle, graduating with honors in 1983. He also followed up with his internal medicine and infectious disease residencies at Emory. And subsequently in 1989, he returned to Mexico, where he was executive director of the National AIDS Council of Mexico for 5 years, responsible for AIDS policy throughout Mexico. In November 1996, he returned to Emory, where he's involved in patient care, teaching, and research. And as I mentioned, not only with the great work that he's been doing at Emory, the work that I've seen him both present and articulate, as well as just prescient thinking. Many of you may have seen him on, I know that I've seen him on CNN, MSNBC, and others, but more importantly, for all the great work where he inspires those of us in public health and the medical community. And with that, I'm going to turn it over to Dr. Del Rio for his presentation today.
Thank you very much, Scott. I really appreciate the invitation and appreciate the introduction. And it's a pleasure to be here and to be able to talk to this group. Obviously, you know, I'll start by saying that I am a physician and I'm somebody who works in public health, but I've never been an expert in communication. And I have learned communication as a result of a little bit of the result of my work, right? As a result of what I do on a daily life. And I'm going to try to share that. And I say that because obviously I'm not an expert in communication, and I look forward to hear what you all have to say. So let me tell you a little bit about why communication, how I got interested in communication and crisis communication, Well, I think it started in 1994 when I was in Mexico as director of the National AIDS Program, and you know, the peso value was cut in half. There was inflation, there was severe recession, and there was a major economic crisis. And I had to communicate with my employees. I had to communicate with my employees at the National AIDS Council. We had to get, you know, let go of several hundreds of people. And it was really important to learn how to communicate and how to do this in a way that wasn't, you know, negative, and it was very hard time. So I learned a lot about how people communicated during those settings. But then in 2000 and 2007, when I was here in Atlanta and I was chief of medicine at Grady Memorial Hospital, you know, the hospital was in a significant deficit, could barely pay payroll, had a big deficit, and a major safety net hospital was about to close. And actually, the dean of the medical school here sent me specifically to learn how to communicate, how to be able to communicate the message during crisis, how to get the message across about the importance of Grady, what needed to be done. And I received formal trainings. So over a 2-day period, I got really coached on how to communicate and how to do this. And from then on, I really have continued using those skills that I learned about how to do crisis communication. And you know, this thing is frequently said, and is not necessarily true, but I like it. Is the fact that crisis is also a time of opportunity, and you have to think about how to use crisis in a way to get a message, not only about, you know, the world is ending, but what is the world going to look like after this, and how can we make a better world, and how can we think about the positive future. So we first have to differentiate risk communication from crisis communication, right? Risk communication is how you deal with what may happen. So, you know, many of us have been saying for years, oh, you know, there probably is going to be a pandemic of influenza. We need to be ready for a pandemic. And, you know, today, as a matter of fact, I wrote an op-ed for a journal about antibiotic resistance. And, you know, this is a crisis that is going to happen. And one of the things you realize is that risk communication is really hard. Think about talking about climate change. You know, you talked about it, you say it, but people don't see it as real. It's very difficult for people to understand risk, and risk is something that most people don't understand. You know, people want to know what's the risk of my kids getting monkeypox when they go to school. I remember being asked frequently in the news and in the press, well, do kids have a risk of acquiring monkeypox when they go to school? And, you know, I frequently would tell the reporters, I said, look, kids have a greater risk of getting shot by going to school, you know. But again, people don't want to hear that. We're not very good at risk perception as humans. And I think that's something that we all need to understand. Crisis is very different. Crisis communication deals with what just happened or is still happening. And crisis communication is really different because here actually sort of the problem has occurred, and, you know, the house is burning, the industry is crashing, the economy is crashing, the pandemic is killing people. How do you communicate? What is the kind of communication you need to do with those at that point? And those are very different ways of communicating. Now, one of the things also is that in my field, infectious disease, we need to acknowledge that infectious disease often leads to rational behavior. And you can go back and think about HIV, think about SARS, think about pandemic influenza, Ebola, Zika, COVID-19. So telling people, oh, we're going to be rational and tell you about the science. Well, we need to understand that people actually are going to behave irrationally. And irrationality is part of the behavior to infectious disease. And I think we need to acknowledge that, because otherwise we say, well, people didn't listen. We told them and they didn't understand. Well, sometimes irrational thinking is not going to change how people react to infectious diseases. So what are the principles of crisis communication in infectious disease? Well, one of the things that I always remind myself is that one characteristic of public health crises is that surprises happen, right? Pathogens and people behave in unexpected ways. I mean, think about COVID. Think about how I don't think any of us suspected that we were going to have so many variants and so many changes, and the virus was going to mutate and change so much, people behave in unexpected ways. People may, decide to stop wearing masks. People may decide to do this. Think about monkeypox. Why has monkeypox cases gone down so quickly? Probably because high-risk populations started decreasing the number of sex partners, and people behave in different ways, and that changes how pathogens behave. We need to acknowledge also that things are going to go wrong. We're going to make mistakes, and we need to recognize that from the beginning. We don't know everything. We didn't know everything about COVID. So at the beginning, we said, you don't need a mask. Then we said, you do need a mask. Then we said, you need more masks. Then we said, we need a triple mask. We're making mistakes. We're going to be wrong. And we need to acknowledge that being wrong is okay. It's going to happen. And as a result of that, policies are going to have to be changed in real time. And if you don't explain this well, you lose trust in people. They say, well, you told me I didn't need a mask, and now you tell me I need a mask. You were lying to me. And we need to be able to explain that, no, the science is evolving, what knowledge is evolving, and therefore we're changing our recommendations. The second thing is, I think we need to understand that there's going to be some flailing. As government officials, as public health officials, as public health spokespersons, we tend to think that it's important to hide the flailing. And the reality is that it's better to be transparent and to say it out there. And this is especially likely to happen when the potential issue is frightening to the audience. So, and people are not just protecting their reputations. They think they're protecting the public from panicking. You frequently hear this phrase, well, we didn't tell people everything because we were worried about panic. Well, if you don't tell people everything, eventually they're going to find out, and it's going to backfire on you. And finally, is that you learn as you go. You make some mistakes, you cope as best you can with uncertainty about what's going to happen, and you handle it the best you can. And I think that, it reminds me of a little bit like going down rapids in a raft. You're going to be hitting rocks, you're going to be being thrown around all the time, and you need to sit straight, you need to sit tight, but you need to be agile, you need to respond quickly. So some of the people that I've learned the most from communication are the following. The first of them is Jeff Copeland, because Jeff Copeland, when he was CDC director during the 2001 anthrax, did many things the right way. He was very good at communication. One of the things he said is we will learn things in the coming weeks that we will then wish we had known when we started. And I think that's a really important lesson. I mean, Jeff said this, one of the first things when he stood up in the front of the podium, he said, we will learn things in the coming weeks that we will then wish we had known when we started. And I think that's a really important lesson, right? Communicate, be very transparent, saying we don't know everything today. We're going to learn stuff later that we wish we knew today, but we don't. So we're going to have to change the recommendations. The second one, and probably the best communicator that CDC has ever had in my mind, was Rich Besser. And Rich, as you remember, then went on after the pandemic influenza of 2009, went on to be the medical correspondent for ABC News. And that wasn't an accident. He was an incredible communicator. And again, look at what he said. I want to acknowledge the importance of uncertainty. At the early stages of an outbreak, there's much uncertainty, and probably more than everybody would like. Our guidelines and advice are likely to be interim and fluid, subject to change as we learn more. So clear. Both him and Copeland are saying the exact same thing. We're going to be changing things. And they said this from the beginning. It wasn't like we got this under control, don't worry. It was, look, we're learning as we go. And then finally, David Hinman, who, when he was the WHO during the SARS epidemic of 2002, 2003, he said, we're building our boat and sailing at the same time. So in other words, you are doing things as you're trying to advance things. And therefore, this is not easy. You don't have all the luxury of making everything right from the beginning. And this is also a very important lesson to tell people. So there's fear. People have a lot of fear during a crisis. And what are the three most important weapons you have at your disposal to attack fear in a crisis? Well, the first one is transparency. You have to be very transparent about what we know, what we don't know, what we're doing. The second one is truth. Speak with the truth. Say exactly what you know, and don't try to hide anything. And the third one is constant communication. You have to be out there frequently. You have to be out there answering questions. You have to be visible. You have to say it as it is. But I think one of the most important lessons is during an outbreak, we all have a strategy. Everybody says we know what we're doing until things happen. Or as Muhammad Ali said, everyone has a plan till they get punched in the mouth, right? I mean, once you get punched in the mouth, your plan goes to hell. And this is exactly what happened. Everybody says, we all had pandemic plans. We all had pandemic preparedness plans. And then things happen and everything didn't work. So one of the most important lessons that I had is during a crisis communication, the best way to communicate is a combination of confident tone and tentative content. Confident tone and tentative content. You don't know what's going to happen next. You may have to change a bunch of policies after you know what works and what doesn't work. And there will be screw-ups. And coping with chaos and uncertainty goes with the job as a leader. So you have to get used to it. And the most important thing is to not freak out, to really be calm, be sure, be confident, but at the same time be tentative. So what are the things that are important to do? In crisis management, Bernstein says that the following things are critical. Number one, you have to identify and get to know your communications team. So one of the most important things early on is I got to know the Emory, communications team. I got to work with them closely. Your communication teams are your best friends. The second thing is you have to anticipate that things will go wrong. You have to establish a good communication system. You have to identify who your stakeholders are, and you have to develop statements. You constantly have to develop statements to update people on what's going on. So at the same time, what are the things you shouldn't do during a crisis? Well, you don't play ostrich. You don't start working on a potential crisis situation once the public knows about it. You don't let your reputation speak for yourself. Well, I'm CDC, I got all the reputation. No, absolutely not. You never treat the media like your enemy. That's going to go against you. You never get stuck in a reactive mode. You have to be proactive. You have to be ahead of the message. You have to be ahead of what things happen. You have to use language that the audience understands. You cannot use language that the audience doesn't understand. You have to listen to stakeholders. Listening to the public is critically important. You cannot assume that truth will trump all the time. You have to address feelings. People have feelings. People have fears. You have to address feelings, not just facts. Don't just make written statements. Making written statements doesn't work. And then you cannot do the same thing over and over and expect different results. So CDC uses this, and I learned this very early on. But you see, many years ago, I learned at CDC that they have something called SOCO, Single Overriding Communication Objectives. This is the risk communication strategy preferred by CDC. It tells you to stick to your key message as much as possible. When asked anything else, you try to bring big things back to SOCO. So your message today is about the utility of masks or the utility of vaccines. When somebody asks you about something else, you bring them back to vaccines. Well, what about hand sanitation? And you can say hand sanitation is important, but getting vaccinated is even more important. Always get back to that message. Always figure out what is the objective you have and bring the message back to that. Now, today, in this day and age, we're dealing with the digital age. And digital age changes dramatically the way we communicate. And I think none of us is prepared for crisis communication in the digital age. And again, we're learning it as we go. But a couple of key things, a couple of key messages to me is, number one, you have to be prompt. Once something gets out there, it's going to be rapidly going to get on Twitter, rapidly is going to be disseminated. You have to be compassionate. You have to listen to people's feelings first, because if you don't, they won't listen to your facts. You have to be honest. Not lying by commission, by omission, or understatement or an exaggeration of the purpose of bifurcating the truth, trying to spin things, is a bad idea. You have to be informative, answer the basic journalistic interrogatives, the who, the what, the why, the when, the where, and the how. I mean, journalists do this very well. Well, you have to do it, you have to say the same things. And finally, you have to be interactive. In our digital age, providing stakeholders multiple multimedia for asking questions and engaging is incredibly useful. So you have to learn how to use this media in an effective way, not just to put statements, but to engage with people. So together with some colleagues, infectious disease colleagues, including Jasmine Marcelin and many others, we published this paper about, how the field of infectious disease can leverage digital strategies and social media during a pandemic. What are the things that we can do in social media during a pandemic that could be useful? And there are many things, and our Infectious Society of America digital strategy response included development of dissemination of guidelines, a user-friendly interface in our website, a podcast, a clinician call to answer questions from clinicians, newsletters, social media posts, infographics, science posts, but you have to invest in that. When you do this, a society has to invest resources and people into making this happen. It doesn't happen on its own. So let's move on to talking a little bit about misinformation and public health. We live in an age of misinformation, and I think we need to be aware of it, and we need to confront it, straight and straight on. You cannot just ignore it. And Dr. Tedros, the director of WHO, has done exactly that. Dr. Tedros said, we're not just fighting an epidemic, we're fighting an infodemic. Fake news spreads faster and more easily than the virus, and is just as dangerous. So I think the head of WHO is attacking the infodemic as much as he's attacking the virus. And in fact, in May of 2020, WHO had this post: false information on COVID-19 is spreading and putting people in danger. Make sure to double check everything you hear against trusted sources. For accurate information on coronavirus, find official advice from country public health authorities and WHO. So early on in the pandemic, there was a lot of misinformation, and WHO had already started to combat misinformation. What is misinformation? Well, misinformation is information that is false, inaccurate, or misleading, according to the best available evidence at that time. And then there's disinformation. And disinformation is misinformation spread intentionally to serve a malicious purpose, such as to trick people into believing something for financial gain or political advantage. We have heard the term fake news a lot during this epidemic. And one thing is that fake news travels faster than real news. And online polarization has been at the center of this pandemic. And fake news and sophisticated disinformation campaigns are a growing problem. And the question is, who did it? Who published it? What are they doing? So misinformation and disinformation is about manipulating people. And people get manipulated for impersonation, for conspiracy theories, for emotional issues, to polarize society, to discredit somebody, or simply for trolling. Now, disinformation is not a new phenomenon, but it's a growing phenomenon in the internet area and in social media area. And as social media can amplify misinformation so quickly, more quickly than ever before. So, what is the role of physicians and other public health professionals in the era of social media? Do we have a responsibility to fight against this new age of pandemic that spreads more widely than we've seen before? Is social media something that we continue to face and will continue to face in the years to come? So how do people find their information? Well, it turns out that 3 out of 4 Americans now get their information online. And 82% of the US population had a social network profile last year. However, very few social media platforms attempt to differentiate between credible and uncredible sources of health information, leaving consumers to make their own judgments. And misinformation can proliferate in part because we tend to surround ourselves with like-minded people online and in real life. And this creates an echo chamber that reflects and reinforces our own viewpoints and beliefs. And in addition to this, social media algorithms serve up similar content based on what you previously viewed. And this again creates reinforcement loops on that information, right? So then misinformation confuses and dilutes the pool of legitimate information. And conspiracy theories then work because they provide the comfort of an explanation in a time of anxiety and uncertainty. And this messaging revolves around core emotions and values and hijacks that mental cues that help us decide what is true, legitimate, and what should be trusted. And the more pervasive and damaging conspiracy theories actually incorporate grains of truth. And we need to understand who benefits from misinformation. Is it a financial gain? Is it a political gain? Is it experimental manipulation? So let's put an example. Here's a clear example. The anti-vaccination industry is a great example of this. It is wellness and nutritional supplement companies that are the major backers and directly profit from anti-vaccination campaigns. Anti-vaccination content reaches up to 58 million online followers and is deliberately retained by social media giants, creating a community because it creates advertising revenue of over $1 billion, right? So they want to have it there because the nutrition and wellness and supplement companies pay them a lot of money in revenue. And the problem is that hesitancy against one vaccine quickly transposes into hesitancy against other vaccines. And we're seeing right now rates of measles immunization and polio and many other vaccinations go down because of the hesitancy caused by the COVID vaccination. So what we've learned is that in this era, in this role of social media, is this era, the information vacuum where there's no clear messaging from public health, or it's too early to have empirical evidence, then gets filled. Those lots of untruths are discussed there in social media. But correcting misinformation is not easy. The fundamental problem with misinformation is that once people heard it, they tend to believe it and act on it, even after it's been corrected. This is, think about how many times there's been articles saying that aluminum doesn't cause autism, yet everybody quotes that article as it was the truth. Misinformation is such a big problem that the Surgeon General recently issued this report confronting health misinformation. What does the Surgeon General recommend? Why is this such a big problem? And what you read in here is that misinformation is often framed in a sensational emotional matter that can connect visceral, distort memory, align with cognitive biases, and heighten psychological responses such as anxiety. People can feel a sense of urgency to react to and share emotionally charged misinformation with others, enabling to spread quickly and go viral. At the National Academy of Medicine, we have also been involved in addressing misinformation. And in fact, one of the projects of the National Academy is how do we identify credible source of health information in social media? And what are the ways in which we can work with communications companies to do this? And thanks to the collaboration with Google, now there is, using these principles that were put together by the National Academy, Google is now beginning to label, YouTube videos and others as being credible or not being credible as a result of this. So how do you identify a credible source of information? Well, trustworthy sources share science-based information without financial incentives and with transparency about where the evidence comes from. And credible sources of health information have to meet three foundational principles. They need to provide information that is consistent with the best scientific evidence available at the time. They have to be objective, and they have to be transparent and accountable. So what are some of the lessons that I've learned in crisis communication? Well, I think that damaging information, when it's present on the internet, spreads virally and gets reprinted by other websites and gets pulled into organizations. And ignoring it just makes matter worse. It's better just to go and confront it directly. With rare exceptions, Media interview skills are not part of the training of a physician or a PhD scientist. And we need, as physicians, as public health employees, as public health leaders, to be trained on communication. Because the ability to make a flawless presentation at a conference does not translate into the ability to communicate on camera or to do a media interview. I think effective spokespersons in a crisis must come across as compassionate, confident, and competent. And I always remind myself that sometimes it's wiser to make peace than to be right. And sometimes you just don't engage with people if they're attacking you. It's really important to avoid getting into a public spat with powerful organizations such as government agencies, the media. They have big stakes and they have long memories. And any significant decision has a public health impact, intentionally or unintentionally, and should be considered in that light before being finalized. I mean, before you make a decision, somebody's going to find out about a policy that you developed. Somebody's going to find out about that recommendation. So you need to realize that before you actually go public with it. As Scott mentioned, I was part of a committee together with your dean that worked on a Delphi consensus about how to end the public health, the COVID-19 as a public health threat. And this was recently published in Nature. And I think there are three pillars to this. And number one is that we need to all work together, right? We need to work as a whole society, as a whole of government. We really need to be data-driven. We need to have meaningful multidisciplinary collaboration. I mean, I think one of the major mistakes throughout this crisis has been not involving communications experts from day one. Number two is we need to build trust. I think trust in public health has been one of the major victims of this pandemic. We have to get back in building trust. And we need to encourage two-way communication, and we need to focus much less on blame and more on a collective solution. I mean, I think that messaging of, this is a pandemic of the unvaccinated. Well, it was always a pandemic of the unvaccinated. Before we had vaccines, it was a pandemic of the unvaccinated. So don't blame people for doing something. Try to understand why they do it and try to change their behavior. And finally, you have to build consensus. You have to really come to a credible point at which everybody agrees on what needs to be done, because doing this will make a difference. And I think it's very clear that we never were able to develop consensus. We always started pointing fingers, blaming the Chinese, blaming this, blaming that, instead of realizing how do we address this collectively and together. So in conclusion, I think communication is a critical part of crisis response. And as I said, during a public health crisis, we just have not involved the communication teams as much as we should. And we really need these multidisciplinary teams in which communications experts are part of it. I think we need to learn that positive framing is always more important. So think about positive framing in the messaging. And trust is at the center of crisis communication. And one lesson that I learned many years ago is that somebody taught me that it's important during crisis to be a rock. And by being a rock, what they mean is you need to be reliable, you need to be open, you need to be competent, and you need to be kind. And reliability means that you have to do what you're going to say you're going to do, right? You have to be consistent. You have to be open, you have to be truthful and transparent. You have to be competent. So you need to know what you're talking about. And you have to be kind, you have to be empathic, you have to listen to people, you have to listen to their concern, and you have to understand why people are doing what they're doing. Because if you're not, you're going to lose their trust. And I think throughout this pandemic, one thing that happened over and over is that we lost trust of people. And we lost trust in people because we weren't truthful, we weren't transparent, we weren't reliable. And most importantly, I think we weren't kind with each other. And kindness, I think, is a critical component of communication. So with that, Scott, I'll end and happy to answer questions and get involved with the dialogue with you.
Well, thank you, Carlos. This is just an excellent presentation and broad scope for all of us here in both risk communication, crisis communication, health communication, media relations, and the challenges that we all face. And You also touched upon areas that we have many people here that focus on, Professor Dennis Nash, on implementation science, and others who are on here. And you mentioned that we sail in the boat, or while we're building the boat or putting the sails up. I mean, people use different metaphors for implementation science, and clearly the pandemic's put a lot in our place. Put our public health people in our place. But I'm gonna start with the first question, and then we have the opportunity for those of you who are on live in the chat function. Is at the very beginning you spoke about transparency, truth, and constant communication. And to be frank, all of this was very well driven and science based. So I want to thank you for the great presentation and bringing up multiple fields and people who've lived it, whether it's Jeff Copeland and Rich Besser, and certainly yourself as a leader in this space. But one area that I continue to hear, and I'd like you to maybe comment on in the early phase of COVID, as we bridge from, okay, what we've learned in the past and what we're learning now as we're still living it, is that so many times we heard, and I will put Anthony Fauci on as the chief medical officer and head of AID and everything else, kept saying, we're following the data, we're following the data, we're following the data. And I say data, data, data. And in your talk, you did a great job and only mentioned data in terms of the Nature Consensus Panel. And we are obviously the field of public health. We have our students are trained in data. But I'd like you to comment on how the data changes and how the data may be imprecise, and how a data-driven system might have led us to places that I think you mentioned didn't get us to where maybe we wanted to go with COVID and the trust, and just reckons back to someone that I think of, former Assistant Secretary of State and diplomat and Professor Harlan Cleveland, who wrote about information everywhere in a nobody in charge world, his book Nobody in Charge. And the fact that we have lived COVID now, and we have the challenges that you've mentioned. How do you feel we can address the challenges in public health and communication, given what you've put forward and what you maybe witnessed thus far today?
Well, I think that the first issue is, when we heard we followed the data. I think the problem is we didn't have any data, right? So at the beginning, the recommendations were based on really the best available knowledge at that time, and I think there was a lot of mistakes in saying we got this under control. We know what's going on. We got this under control. Part of it obviously came from we were dealing with an administration, a president that said in 2 weeks this is going to go away. It's going to disappear. So the leadership was setting expectations that were not true, and I think we failed to say, look, we don't know what's going on, and we also didn't want to sound weak. Like we're trying to do our best based on what we have. I think the second thing is again, there was a lot of anxiety and a lot of fear, and we didn't listen, we didn't respond to people's emotions the way we should. I mean, I think there was a need to have somebody up there who was really willing to almost to be like a minister or a spiritual leader who provided the comfort that people needed, who provided the support in the times of anxiety. I mean, I think, for those of us working in hospitals, it was very tense to see people that, were dying and they couldn't even have their loved ones come and join them at the bedside, right? And this was, this was incredibly hard. I used to tell people from the early days of HIV, when people were dying, well, at least when people were dying with HIV early on, you could have the families at the bedside. People were there. You could hold hands with the person. Nowadays, we have all this PPE and all this other stuff that prevented us from. So we also created policies in our hospitals that honestly were absolutely irrational to what human behavior, to what human needs are. And isolation became a driver of this. And, humans are not made for isolation. When you tell people, I mean, you're seeing what's going on in China, that people are, revolting against the government because of the zero COVID policy. I think we need to recognize that humans don't do well when you separate them, when you isolate them. And we did not recognize that from the very beginning, that this was going to be bad. This was going to be bad for society. This was going to be bad for people willing to put up with things. And then we didn't use the power of community. And I think early on, I think that we failed to recognize that pandemics disproportionately impact the poor and the underserved. And we should have known that from day one, because pandemics do that. And instead of doing that, it took us a while to recognize the disproportionate impact on minority populations. And therefore, there was a big chunk of the population that felt that once again, they were being ignored, right? Once again, they were being left behind. Once again, they were not being paid attention to. And therefore, that created a lot it just fed on the mistrust that existed in the system. So I think we failed to recognize the human side of a pandemic and the societal side of the pandemic. So while I think data is important, I again think that sometimes we need to listen to what people's needs are, and we need to listen to what people's fears are, and we need to address them before we go into oh, this is the data and you have to follow the data, because otherwise people don't follow the data. I see this all the time as an HIV provider, right? I mean, for me, the most important thing may be that you take your antiretroviral medications, but for many of my patients, the most important thing is to find where to sleep tonight and how to feed their families and how to do this. And we did a study many years ago, HPTN 061, in which we thought that I was part of this this network study, multi-site study, in which the theory was that we could use health navigators to get young gay men, to get tested for HIV, a link to care, and if we did that, they were going to do better. And we learned very quickly that young gay men were really not interested in a health navigator to help them find HIV testing. They were interested in a health navigator to help them, get a job, clean their criminal record, find housing. That's what they wanted. That's what their needs were. And I think not addressing their needs and saying, from our perspective, well, HIV is what you need to be concerned about, was wrong. We needed to first address their needs and then come with the HIV component. And I think that, to me, is a really important lesson, is that you have to understand, you have to listen to people's needs and address them before you go and address what you think the data suggests.
Yeah, no, I mean, really, thank you for answering that in such a comprehensive way, and again for even the communicator is the HIV lapel pin, and both me personally remembering, it was the mid 1980s when I was at medical school at USC, and had some of the first HIV patients that were presenting in those days, and the stigma, and even before it was called HIV at the time, and subsequently worked on a book on that, and many of the things that you say are still, as you say, true in each one of these crises. And the whole idea of not only the ethos of the individual saying it, the pathos or the understanding the individual and the emotions are oftentimes, as you're saying, more important than what we think as scientists, sometimes the logos, the logic. And I'm just sort of paraphrasing, Aristotle in the midst of this. But, what I'd also like to we have our hand raised from our distinguished professor, Dennis Nash, in our epidemiology biostatistics area. Dennis, I think are unmuted, and turn it over to you.
Thank you, Scott, and thanks, Carlos, for being here at CUNY today. It's great to have you here. I wanted to just say, like, a lot of things resonated with your talk, and I feel like we have this communications crisis has really damaged the reputation of CDC, and I think it damaged the reputation of public health more broadly. And so we have a lot of recovery and work to do. And the few things that resonated with me in your talk and your slides are the quote from Rich Besser, which I think starts from a place of humility and talking about uncertainty. And it basically is saying that in some situations, it's important to convey that we just don't know right now. And also Jeff Copeland's quote, but we're going to learn things. And that to me is one of the missed opportunities for CDC. And it gets to the follow the data piece too, because if I used to think, and I come from working at CDC as well, I used to think that CDC was the role of CDC in a situation like this is to be one of the premier generators of data and evidence about what to do next. It turns out in this pandemic, they were not. I think the UK was a leader in this area. Not that they generated some awesome data and evidence. They didn't necessarily follow it in their day-to-day practice and implementation, but I feel like a real missed opportunity was for CDC to say, look, we don't know right now, but we are the CDC and we are going to empower health departments and hospitals to gather the necessary evidence that we need, or to do the rapid implementation trials that we can do to learn things quickly to then inform practice going forward. We saw none of that. And we, in fact, I feel like CDC was often the last, entity to sort of acknowledge a lot of really important evolving evidence out there in the rest of the world. So I think there's something to recover from there, and it gets the other connection I made was the Chinese writing on what it represented, both danger and opportunity. And I feel like we focused mainly on the danger and not so much on the opportunity from the public health side. Lastly, and my question for you is just like, I feel like politicians also took the communication reins away from the subject matter experts in government and at CDC often, and that happened in both administrations, I think. And I wondered if you see that as a trend that needs to be addressed going forward.
Yeah, no, I think so, and I think that we also, the other thing that I saw that was different also is that we didn't use we also didn't use some of the real experts, right? I mean, early on, when all of a sudden, when one of the days I saw on the podium Ann Schuckert, I said, great, Ann knows what she's doing. And then she was rapidly eliminated and never used again. And so the bench of CDC had some really solid scientists and communicators that should have been used and should have been up there. And I can see the president, I can see the CDC director, I can see Tony Fauci saying, look, here's the message, but let me bring this expert. Let me bring this person who's going to explain this further. And I've never saw that done. And that to me was also a missed opportunity. Why not bring somebody who really bring somebody that is more sort of diffuse the people that give the message, right? At some point in time, I think people got tired of listening to Tony Fauci because you either believe in Tony or you didn't. And if you didn't, then you were not going to listen again, right? And then you start attacking him. And I think there was a need to involve more of the outstanding people that work at CDC, outstanding scientists. I mean, we have a problem with testing. Let's get the testing people to explain to us what's going on. We have a problem with this. We need to understand masking. Let's get somebody to explain to us what's going on. We never used multimedia in an effective way to explain how the masks work. We could have done some really good graphics and animations showing this. So I think we didn't use all the tools at our disposal in communicating. And part of it, I think, was, in the past administration, at the beginning was, as I said, a lot of trying to minimize the problem. But also in this administration, we've gone into the same problem. Oh, it's over, we've done. I mean, I think this administration has put all its eggs in one basket, vaccines. And we have pushed vaccination as the only strategy. And there are multiple other strategies that could have been used. And again, we haven't communicated effectively. What are the other strategies? How do we use testing? How do we do this? How do we better look at this approach? we failed to really, I mean, think about how long it took. Think about in December when Omicron started, that at one of the press conferences, the press secretary said, well, I think a reporter asked about testing, and a press secretary said, well, do you want us to send tests to every home in the country? Well, yes, that's exactly what we needed. But she was taking it like an insult, like a joke. And at the end of the day, that's exactly what they did. But instead of saying, that's a really good idea and we're thinking about how to implement, we actually mocked the idea, and then we actually ended up doing it. So I think there were a lot of errors of honestly of humility.
No, thank you for both the question and the illustrative responses to where we are today. And I know that our dean has given a lot of thinking in this, notwithstanding getting almost 400 experts from around the world, including yourself. And our dean would like to ask the next question. Amen. I think you'll be unmuted.
Thank you for allowing me to unmute and put myself on camera. Professor Del Rio, thank you very much for an insightful and meaningful contribution to the school today, to our academic community, and to scholarship. I will say that of the many slides that you presented, a slide that is missing in my own mind and my experience was a slide on leadership. And unfortunately, COVID has exposed us to a life reality where unless science, unless public health and leadership are aligned, we are in the midst of a second crisis. And you have said that in not so many words, where people who are sources of knowledge were not allowed to speak, and people who are experts were undercut, and doubt was placed in their messaging. And I will also say that it is part of leadership's role to exercise what you described so aptly as truth and humility. But also it is the responsibility of science, as you described, to adhere to intellectual, but also ethical humility. Finally, what we also examined was that misinformation was allowed to be rampant because there was no direction from leadership. And there were many, many opportunities leadership had. And I'm talking obviously as to the supreme leadership of the country at that time, the President of the United States, where he could have contributed in many ways at putting an end to misinformation in its bud, but was allowing it to flourish to a point where it became in itself a pandemic that was hard to control. So I would like to invite you to speak a little bit about leadership, which you yourself have exerted in many situations, and to perhaps explain a little bit what happened to CDC at that moment, because like Dennis, I was frustrated in multiple occasions, but at the same time, I must admit that it doesn't help anyone for us at this moment to continue to either blame or take away the trust that the public health community needs to have in the CDC. So I will let you respond.
Oh.
And I thank you for being with us today. It's a great honor to us.
Thank you, Amen. I think you make some very important points. Yeah, leadership is critically important, and leadership was obviously at the, when the pandemic started. I mean, I think we've seen, the government created pandemic preparedness plans, but never in the plans there was a chapter on what happens if we have a crazy president as leader, right? I mean, how are we going to deal with that? That chapter didn't exist. Everybody assumed that leadership was going to do the right thing, right? So I think from the very beginning, leadership was incredibly dysfunctional, and dysfunctionality of leader led to just dysfunctionality in the team, right? The team that responded to the pandemic became dysfunctional. And, it's not the fault of Dr. Fauci. It's not the fault of Dr. Birx. I mean, I spoke to Debbie and Tony back then, literally on a weekly basis or more frequent than that. And they were frustrated. They were like, what, we don't know what to do. What's going on? And there were a lot of politics got in the middle of it significantly. And then, it was the president himself, promoting misinformation. And I would say the good thing is that the best thing the past administration did was obviously, Operation Warp Speed. That was a huge accomplishment. But then there was, even politics got in the middle of it. I would say that, having, for example, the results of the remdesivir study, the way they were made available first was at the Oval Office, right? I mean, that's crazy. We can't have science and politics be mixed so much, right? So I think science and politics got mixed from the beginning. And honestly, then came, the Biden administration. And for the Biden administration, what ended up happening is, I think they started well, but then Delta came, and and then Delta derailed everything, right? Because we were going great, and then Dr. Walensky, CDC director, said you can take your mask off, we're doing fine. And then Delta hits, and we realized that, oh my God, these vaccines don't prevent you from getting infected. And guess what? We knew from day one these vaccines didn't prevent from getting infected. The studies were done not to show that the vaccines prevented infection, but they prevented severe disease and death. But we never communicated that effectively. We never said these vaccines are not intended to prevent infection. And because we didn't communicate that from day one, and then we acted as if the vaccines prevented infection, I think at that point in time, we lost all credibility. The vaccines, nobody said, hey, the vaccines don't work. You're still getting infected. You still have to use a mask. So I think that, again, I go back to not being honest and not being transparent, because we should have said from day one, these vaccines don't prevent infection. They were never intended to prevent infection. And therefore, that's not the outcome we're looking at. But because they initially prevented infection, we said, oh, this is great. But then once the virus changed and Delta appeared and they didn't prevent infection, and where we are right now, these vaccines don't prevent infection at all, right? So I think that's one of the issues. But the other issues is, again, that we have failed to, I think the virus has moved so fast and so quickly that we have failed to engage the right people from the beginning. And we, the FDA never put together a group and say, hey, how can we get a rapid test approved quickly? How can we do this? How can we do that? And those things, I think, hamper the response. So people started, the amount of side chatter about the credibility of different organizations, including, the CDC, the FDA, the NIH, just grew bigger and bigger. And I think somehow we have to rein that. And, one of the questions here is, how can public health professionals respond to people or organizations that do not accept us as credible? Well, I think the first thing we have to rebuild is credibility, right? Somehow we need to figure out where we lost the credibility and how do we regain it. And that's going to take a lot of, I would say, mea culpa. I think it's going to be really important to recognize the mistakes and correct the mistakes that were made. And we need to be very honest about why we made those mistakes and how can we correct them. And it's going to require leadership willing to do that. And I think it's going to be really hard.
Yeah, no, thank you for that honest answer, and also our dean's question on leadership. Part of my applied research, I work with business organizations, and with the U.S. Council for International Business, we just launched "There's More to Be Done," that leadership matters. This is leadership, of course, at the business level to follow good public health guidance. But what we can do, and I think some of the questions in the chat are, what we can do with both leadership and public health to what you even mentioned, that the remdesivir studies are released at the White House. What's driving me crazy is these not even preprints, but press releases that are announced by a CEO of a company of what should be done, whether it's about, treatment or vaccines or anything, related to what used to be, good peer-reviewed scientific data and progress. So a couple of people in the chat have asked, and then I'll turn over to Pedro, one of our professors next, about if you can comment on both the data that seems to be flowing from press releases, non-published articles, preprints, and so forth, as well as if you have any ideas on ways to help. I think you just answered it on the CDC and others to build trust. But is this prolific press release science, if we call it that, or not even press releases? A CEO gets on and says, "Oh, we have the study of X, and this is what we hope," and it moves the markets. And before you know it, you've got chatter over social media and a different viral world than we used to have. So, is there any way we can rein that in, or are we? Is that our?
No, I think we can rein it in, and I think also preprint servers are the reality of, a lot of things are in preprint service, and now the peer review is happening on Twitter and other social media platforms. And I think what we need to is figure out how do we do that in a more transparent way, and how do we read those preprints in a critical way and look at them. The release of findings on press releases from companies is it's very frustrating. And I wish the only thing that would happen is that those press releases from companies would occur at the same time that at least the data is released on a preprint server. I mean, I think that would be something that I would demand, right? That, look, you're going to release your press release. That means you have the data. You have to at least release a preprint. I mean, I understand that your paper may still be percolating in New England Journal of Medicine or Lancet, but you still, you can easily put your paper in a preprint server so people can look at the data. Because so many times I would be asked by a reporter, "What do you think about this about this, vaccine working, this, that?" I'd say, I want to see the data. I mean, press release is not data, right? It's a marketing tool. It's a business tool. And so I think we need to somehow say, you can't have a press release without having at least your data somewhere in a preprint server, because you already have it. That's how you gave us that's how you created your press release.
Right. I hope that, I don't know who the proverbial we are on this. Can we get the media journalists behind it? Can we get the
Well, I think it has to be something like the SEC or the FDA, right? Saying, look, It's okay to do a press release, but you have to link it to something that gives information, right?
Yeah. So this is commercial speech, as we call it, which I do think has a different legal ramification as well as a liability if they would say otherwise. And as you say, in the warp speed, I'm sorry to use that pun, and the Operation Warp Speed that Trump used, but the speed of release has made it a challenge, and we want to have the science out there, but it's something that I think is definitely worth discussing, as you mentioned. And thank you for bringing it up. And I should reference the person who's asked this question. So, David Rimland and others who've raised that in the chat. So over to you, Pedro. I see you have your hand patiently raised.
Thank you very much, Professor Del Rio. I really enjoy your conversation, your presentation, and I do think your point that you're making are very important regarding the break of trust in leadership. I think that's very much a given in the current social media. And also you have brought the idea of the importance of what happened during the HIV epidemic. And I think that example is very important, because there we learn that the community, especially during the HIV, the gay community, play a critical role in science. And you also have said, which I really appreciate, that, and I think Dennis as well, that data is not enough. And then there is a huge emotional component that us as public health providers need to understand and to work on. In that realm, again, with the HIV epidemic as a reference, and the fact that CDC has not been up to play, are there any thoughts at the federal level to establish networks of leaderships and trust leaders in different communities and across different networks. So if this were to happen again, we could rely on that community build network, and CDC could, not out of the blue, but actually have worked those networks at the local city, neighborhood, and state levels. So when there is this break of communication, there is more of that social emotional component that we know is there and we can count on. Thank you so much for your presentation.
You know, it's a really good idea. I'm not aware about any efforts at the federal level, but I do think that we have to do that. What you're saying is exactly right. We need community leaders. We need, you know, in HIV, those community leaders have been incredibly valuable and have been really the people that have advanced the science and have done a lot of the work that is necessary. So it's not, I mean, it's a really good idea. I don't know what to say other than I think we need to think about how do we engage the community proactively, right?
Pedro raises a big question, and we had the Surgeon General Vivek Murthy speak at our commencement, and we often ask these questions both publicly and privately. And our data also, we've done, as you know, a number of surveys, both New York, US, and globally, on if people trust government officials for this kind of leadership. And the question might be, if I turn it back to you, Carlos, if it's not at the federal level, is there a place at the scientific or medical community or the national academies? Are there other places of a non-governmental organization, a professional organization, a voluntary organization, an academic institution that can help fill this gap? And, you know, also, as I think that you and a couple of people have asked also in the chat, to help raise the trust, not only in public health, but also in the CDC and the organizations that we've have trusted.
Well, you know, as
Tip
O'Neill said, oh, politics are local. Well, I think, oh, public health is local. I think at the end of the day, we need local communities. We need local experts. We need to work. Local health departments need to work with local communities. And really, I think one of the things that may help is for local health departments to have standing community advisory boards that are working on different community issues, right? I mean, I think we need health departments to have, one of the things that I would do is have health departments have community advisory boards that work with them in the variety of different issues that we're dealing with, whether it's gun violence, whether it's diabetes, whether it's, you know, drug use. I think having community advisory groups and people that can be trusted and can work with the community, in my mind, would be critically important. So I think that would be the first step I would take is have community advisory groups be something that health departments must have and must incorporate.
Mm-hmm. Well, I mean, it's unfortunate. Well, fortunate and unfortunate. Fortunate that you're able to do this via Zoom, and unfortunately we can't see you in person and have you visit our School of Public Health. We say the public school, the leading public school of public health for New York, in New York. And much of our work is with not only the local communities, whether it be, you know, where we're based in Harlem, but also working close with the New York City Department of Health, Mental Hygiene, and others. So we take that very much to heart, and we do want to open that invitation back now that we're almost at the end of I hesitate to say the end as the president have of the COVID pandemic, but at a phase certainly where we're opening and having the same sort of opportunity for integration. But we're very strong believers in that, and I think you know, notwithstanding, you know, what you know about the school, but what you've heard from our faculty and our dean here, so we would like to take that to heart and certainly appreciate your engagement here today, and hope you have the opportunity to join us in the future. Before I close this, I want to, you know, make sure you don't have any questions or other, you know, comments for us. And, you know, I've tried to paraphrase many people in the chat, and if I haven't, please repost something here, or anyone else raise your hand if I haven't seen it. But you know, I really you know, Carlos and Professor Del Rio, you've been just terrific, and notwithstanding it's only the edges of what you've been able to share from your wisdom, but very many pearls that we hope that we could put into place and hope to go in the work in the future.
You know, the other thing I would say, Scott, as we end is, you know, I'm I was trained as an MD, right? Like you, I'm a clinician. And I think one of the things that we learn in pandemics is that public health and clinical medicine need to work together. And what I would also like to see is public health and clinical medicine working together all the time, right? I mean, in our country, we live in the silos of public health lives here and clinical medicine lives here. And we don't work together. And what I would like to see as a result of the pandemic is public health and clinical medicine and community working together. I think changing the way we collaborate, changing the way we think, changing the way we work. The problem is in clinical medicine, the incentives continue to be on people getting sick. The incentives are not on people staying healthy. But we have to change that, because that's one thing the government can do. The government can really change the incentives so public health and clinical medicine work together and work to improve the health of communities, rather than that clinical medicine and the healthcare enterprise being about taking care of the sick.
Yeah. Excuse me, Scott, but I'll butt in. I did not want to mention our recent consensus article in Nature because I did not want this to be an infomercial. But I must admit that you have now that you've mentioned this final point, I must admit that it is so important. And it's one of the elements where 386 experts in the field agreed upon. It was a whole society, whole government approach, the continuum between public health and clinical medicine, a clarity in communications as a very important element. And then the final thing that you pointed at, which is also so very important, is that issue of dealing with the most disenfranchised, dealing with communities that are a low reserve community, either culturally, socioeconomically, or psychologically. And these are all elements put together that we cannot ignore. We've learned so much from that pandemic, and we have certainly learned a great deal from your presentation. So I add my thanks to my very dear colleague, Scott, and I thank him for the wisdom of inviting you today to our grand rounds. Please come back.
Delighted to be and hope to be there in person one day. Thank you so much.
Thank you.
Thank you very much.
Take care.
Okay.